Thank you, Eric. I appreciate the opportunity to speak to you again. I'm going to stand here because I've been instructed to stay behind this microphone so that the people online can hear me. Okay, so there are my disclosures. We're going to talk about EEG, who we should monitor, when to start, and how long to monitor, and so forth. But let's get to it and see what we can learn. This is review. Last time I said that post-cardiac arrest care is really two main activities. When I have a patient who has cardiac arrest and you resuscitate and you have pulses back, I must discover the etiology to fix that, and then I must also treat all the organs that are damaged, particularly the heart and brain. I also like to make a prognosis, and understanding what's going on with the heart and brain is part of making a prognosis, and it's also part of taking care of the damage. So it's customary for us to monitor the heart. We would always look at the blood pressure, the cardiac output, or signs of perfusion. We look at the structural integrity of the heart and what is pumping, and we look at the electrical activity of the heart. The brain is the same. We should look at its function, which is primarily your examination. What can the patient do? We should look at its structure, which we usually do CT scan of the brain as the fastest and quickest. Maybe you do MRI. And then also the electrical activity. I think if you think of that as one-to-one correspondence, it's surprising that we don't use EEG in every patient who has coma. And there is a trend for people to recommend EEG for more and more patients who are unconscious, because the electrical activity may explain both the etiology and then the trajectory. And that's what I'm going to discuss, is that EEG. There are indications from the Society for Intensive Care. It says that EEG in the intensive care unit may be useful for many types of patients, patients with acquired brain injury, and it mentions cardiac arrest as one of those categories. But everything I say, you may get an expert on trauma or an expert on stroke who can recommend similar approaches for those patients. This is one of the ways we prognosticate, and this is a cartoon that describes all the tests you might do when you're trying to discover whether the patient will do well or do poorly. And last time I talked about the initial exam and doing the CAT scan, and then I sort of stopped when we got to EEG, because that's the next thing I can do chronologically. I can examine the patient immediately when I meet them. I can do a CAT scan usually within 1 to 2 hours. And it takes some time to set up EEG, so usually I'm beginning to see brain waves in 4 hours or 6 hours, but not tomorrow. I'm seeing it tonight when I first meet this patient. There are good things and bad things. Maybe I get bad news and I know that the patient will do poorly. Maybe I get good news and I have high enthusiasm that they will do well. When I look at my hospital's use of these tests, everybody is examined. 75% have a CT scan. Maybe it's not done if the patient is wide awake or wakes up promptly. Maybe the same number get EEG. And again, sometimes the CAT scan is so terrible, it's not necessary to do EEG. Sometimes the patient looks so wonderful that it's not necessary to do either one. So not everybody gets every test. And you can see these are much more common for us than MRI or evoked potentials, where we need additional information. And think about what information you get from each of these things. Clinical exam, if I look at the brainstem reflexes, tells me all about the brainstem. It really doesn't tell me if your eyes react or if you're gagging or coughing. It does not tell me about the cortex. The only thing on my exam that tells me whether the cortex is working is really the movement of the arms and legs, yeah? Because I can have extension with just my spinal cord. I can have flexion with just my midbrain. But if I want to localize, or if you stimulate me here and I move over there, the information has to go in my brain, bounce around, and come out someplace else. There needs to be information processing, and that's a cortical activity. This is wonderful, but you meet patients and you anesthetize them and then they're unconscious for many days. The EEG is an additional monitor that you can apply for the cortex. And essentially you put wires on all of the different parts of the scalp, you measure the voltage between the wires, and it's usually presented to you like this, many different tracings where you have each one corresponding to two of those wires and the difference between them and the voltage changes over time. It makes squiggly lines. Now, there are only 3 or 4 neurologists in the audience here in the room, so they look at this all the time. It's very meaningful. The rest of us look at it and we see squiggly lines. There's information there. Maybe this looks like something you've seen before, maybe not. But, today I want to talk about how, we can all look at these tracings and take away information. It's also very important to understand how limited EEG is. So like this graphic I took from a research group, their paper on making interfaces between computers and brain. I don't know if their goal is to make better video games or to help people who are paralyzed, but this is their research. But they made a very nice graphic reminding us how much neuronal activity is required to be able to detect it with wires on your scalp. If I have wires on the scalp, they have to be picking up an electrical signal through bone, glia, skin, fat, and they are going to be looking at that cortex that's underneath it. And within that cortex, they're going to be looking at the electrical potentials and little tiny synapses. And just this small size of neurons makes you realize that to see an electrical impulse out here requires millions and millions of neurons to fire all at the same time. That's what's going to create an electrical potential sufficiently large to be detected outside the scalp. If I open the skull and put an electrode right into the brain, I could record one neuron, yeah? I could have a very small electrode and I could record a single neuron. But outside, it takes millions of neurons working together to make a signal big enough to detect. That means that this is not measuring midbrain. It's not measuring brainstem. It's detecting electrical impulses close to the top, close to where the wire is. So it's a cortical monitor, not a deep brain monitor. There can be significant damage to the deep brain. It's not going to show me on EEG. It's cortex that's going to respond. So in my mind, this is an ancillary test to the motor exam that I use to get cortical response. The electrical activity tells me something about the cortex. And, what would you want your cortex to do? What do I hope your cortex is doing now? I hope it's processing information. I hope all the different brain parts are doing their job. They're doing different things. The left part of your brain's doing something. The right part's doing something different. The front is doing something different than the back. It should be different in all the leads. And it shouldn't be the same thing. If I talk too slowly or the room gets too hot and you become sleepy, then it will become a rhythm of waves and you'll go to sleep. But if it's interesting and there's information processing, you'll have chaotic activity where this second looks different from that second, looks different from that second. So those are obvious things, but this is what your neurologist is telling you when they talk about the tracings. Do they look healthy? Is it variable? Are there different things in every channel? Is there activity all the time? Or is your brain taking breaks every few seconds? And there should be small waves, not really big waves. There's pathology, and there are different definitions of pathology. And this is one that's from the American Clinical Neurophysiology Society. It was a number of years ago, 10 years ago now. And they talked about highly malignant EEG. Because I study cardiac arrest, this was a common finding, and it's a broad definition that I put up here because when you read papers, they will say highly malignant EEG. If you read guidelines, they will say if the patient has a highly malignant EEG. But this includes some things that might actually have recovery. So I want in this lecture to make you think more precisely than just lumping good, continuous, variable, different in every channel, and malignant. It's not just two things. There's lots of information. Oh, here is in fact a guideline. This is the European Resuscitation Council's guideline on prognostication. I like it because it's the same one I showed you from Pittsburgh, but it's turned sideways. So if you rotate my algorithm 90 degrees, it's this algorithm. So, I think we all read the same papers. We all are colleagues and we have very similar approaches. You examine the patient, you wait a period of time, you can do evoked potentials, you can look at EEG, and it actually has in there recommendations about the EEG, and it says that EEG-based predictors like burst suppression, status epilepticus, unreactive are associated with a poor outcome. So that's essentially that same 2013 definition of malignant EEG. It's in the guidelines. What are all those words? There are lots of words there about the EEG. What's the meaning? And I want to walk through some of the definitions and some of the examples so you see what each of those look like. This is a more recent document, which is really a dictionary of what you need to know to understand what your neurophysiologist is telling you. It gives operational definitions, and these operational definitions are useful for research because then when I write a paper and I talk about a particular pattern, I will mean the same thing that you mean. First thing is whether the EEG is continuous. Remember I said the electrical activity should be happening all the time. Your brain should not have big pauses. At the top, there's an electrical wave and it goes all the time. You can see that it might have a pause for a second, so it's almost continuous. It might have pauses every few seconds, it's discontinuous. And then when it gets to be where the pauses are the main thing and the electrical activity is the more rare thing, it's sometimes called burst suppression. And then when it's completely gone, it's suppressed or attenuated, yeah? So this is the first distinction. Is the electrical activity all the time? Or is it none of the time? Or is it somewhere in between? That's suppression. So this is one of our patients, and you put the EEG on, no brain waves. I can tell you that this patient, if I examine them, also probably does not move their arms or legs. If they do, it's going to be extension, because I can do that with my spinal cord. Might be flexion with the brain, with the midbrain, but is not localizing. There's no cortical activity there. This one you can see there's some flat places in between and then some brain waves. So it's maybe some bursts of brain waves and then some flat places in between. What I hope is what you see as a cartoon on the right, that the cortex is quiet now, but that it's improving and it's going to become more active. So if you show me this as a snapshot, and I don't know if this is on day 20 or 20 minutes after cardiac arrest, I don't know what the meaning of this is. If it's only 20 minutes after cardiac arrest, maybe this is good because there's a little bit of activity, and I'm hoping that it's on its way to becoming more activity. If it's been like this for days and days and days, this can have a different significance. So it's very important to think of this as a movie, and one snapshot of a movie is not informative. Not as informative. Oh, and there's continuous background. Lots of noise, artifact, brain waves. It's what we hope. And I had the cartoon there. All the cortex is doing something. It's all making noise. And that's what you hope the patient recovers to. Second term, bursts. Bursts and discharges. You can see their operational definition here. They call it a discharge if it's really short, less than half a second. Call it a burst if it's a bit longer. It's kind of the same thing. It's some electrical activity on a background that's pretty flat. The definitions are important if you guys are reading EEG, but maybe not so important to us who are not neurologists. The later, I think some of these things have special significance after cardiac arrest. So burst suppression would look like this. Most of the time, it's pretty flat, and then there will be a burst of electrical activity. I don't know. It's waves. They're kind of the same in every channel, but it's chaotic. It's a burst. It's suppression. So the name tells you what it is, burst suppression. This is what we hope it's part of, that you're going from that initial suppression during cardiac arrest. Because when your heart stops and there's no blood flow, the electrical activity stops. So everybody starts in suppression. When you get a pulse back, you want it to begin to have electrical activity. You want the electrical activity to become more continuous, and then you want it to be continuous, variable, reactive. Burst suppression, I will maintain, despite that first slide, is not a highly malignant pattern if this is when you see it. Here's another group showing this evolution, and they had the times after cardiac arrest for 2 patients. So you can see that 5 hours and 3 hours after cardiac arrest, which might be the first time you put on your EEG, is pretty flat, very suppressed. By 10 or 12 hours, it's burst suppression, and then 20 hours and 27 hours in these patients, you have continuous activity. So again, this is the trajectory you want your patient to take. The suppression ratio is one way to talk about that. And this is defined as how much time is a burst and how much time is flat. So here, we would talk about 80% suppressed because out of 10 seconds, 8 seconds are flat. If you quantify that, we did this in Pittsburgh, on many, many patients, you'll see that patients have different trajectories. At the top is a red line, and the red line are people who had high suppression, maybe 90%, and they remain suppressed over 36 hours. You can see that in our hospital, only 2% of those people survive, and none of them had good outcome. At the bottom, you had people in blue who had very low suppression. They had continuous EEG, continuous electrical activity the moment we put on the EEG, and it remained that way for 36 hours. And those people had 64% survival, 40% of them had good outcome. So they're comatose patients, but have 50-50 chance of good outcome. And then you have the groups in between, people who rapidly improve, they do a bit better than people who slowly improve. So, what do you take away from this? Well, if your brain is turned off, the faster it comes back to life, the faster your cortex comes back to life, the better. Faster recovery, faster elimination of suppression, the better. And it also gives you a sense of how quickly that happens. This is all unfolding over 36 hours. So putting the EEG on day 3 or 4, you've missed all this, and you don't know this information. Ooh, discharges. Remember, there were bursts, and then short things were discharges. So discharges kind of look like epilepsy. They're sharper, and you have waves, which you can see there, almost look like EKG artifact or EKG QRS complexes in your brain. Well, I told you want your brain as an electrical organ to be doing different things in all the different parts. Your heart, you want to all be synchronized so that it makes muscular activity and it works synchronously. So your brain should always be something like fibrillation. Your heart should always be synchronized. When you get those things mixed up, is bad news. And that's simple EEG. These discharges look like epileptiform discharges, and so they're called generalized epileptiform discharges because they're all over the brain. And most of the pathology I see after cardiac arrest is generalized. Sometimes you get things just on the left or just on the right, but most of the time it's generalized. And they'll be abbreviated as GPEDs or GPDs, generalized periodic discharges. They are something firing in the brain. And, kind of think of them like bad spots in the brain. Something in the cortex is giving off these epileptiform discharges. And maybe it's a little area of brain damage. Maybe it's inflammation. Maybe you can recover, maybe not. Maybe it has good brain around it. Maybe it has no good brain around it. But the thing is, there's a little focus, which I've made like little blue stars on the brain that look like areas of very focal sources of discharges. Here you can see there's a background. So between the discharges, they're brain waves. Good. I like brainwaves. And if you get a lot of them increasing in time, it's a seizure. And the characteristics of a seizure is these epileptiform discharges. They evolve in time or space, and they get fast. You can see clearly here, that one speeds up, and then it changes, and then it stops. So it may stop because of time. Seizure just stops. It may stop because you give a drug, but it evolves over time, and that's a seizure. Now, not all seizures have jerking, right? You can have non-convulsive seizures. And many patients after cardiac arrest will have these electrographic seizures, but they'll look unconscious, they'll look flaccid. Again, without your electrical monitor, you don't know. You don't know if this is happening. If GPEDs happen fast enough, the operational definition is to call it status epilepticus, to call this a seizure. It's shades of gray. So I showed you GPEDs earlier that were maybe happening once per second. If they start happening once every 2 or 3 times per second, it's called a seizure. I refer that as a statutory seizure because it's by definition. It doesn't quite look like the evolution that I showed you for the more classic seizure, but we think this is something that we would consider on the same spectrum as a seizure. Okay. But that's general neurophysiology. We're talking about cardiac arrest. When we meet a cardiac arrest patient, what are we likely to find? I put the EEG on. What kind of patterns will I see? Slow, burst suppression. Those are all continuous, turning into discontinuous modes. Myoclonic status, which we'll come back to later, which is usually GPEDs, is continuous. And then epileptiform discharges. So seizures are not the most common. You can see that the seizures and epileptiform discharges, maybe 20% of patients, 12%, 20%. It varies in different centers, but it's maybe 1 patient in 7, 1 patient in 5, somewhere like that. Much more common are these others, burst suppression and myoclonic status. And only 1/3 of patients have that really good EEG when you first put the electrodes on. Your results may vary. Who survives? Well, it's much better to have been the person with a continuous EEG. So the initial patterns here, you can see among survivors, it was 50% of the survivors have continuous EEG at the beginning. People with seizures also survive, but those other patterns, those GPEDs and suppressed background, those are the really lethal malignant patterns, the ones where few of our patients who are leaving the hospital started out with those malignant patterns. One of my colleagues summarized papers out there from different places. These represent some studies from Europe and Korea and also United States. And there are 10 to 20% of patients have epileptiform discharges when you first put on the EEG, and then maybe 30% have these GPED patterns, which are malignant. The outcomes are worse if you have epileptiform discharges. And this is data from our hospital. The number of people with favorable outcome is in red. And you can see that similar appearing patients have much reduced expectation of survival if they have epileptic discharges. So the presence of those epileptic discharges is not good. It's also not 100% lethal. So it's a difficult patient. This patient is sicker, and their chances of good recovery is lower, but it's not game over. All right, intermission. Let's summarize. That was a lot of physiology. That was like pure didactic, nothing clinical. You're thinking, are you in the wrong lecture? Maybe I will talk about the Krebs cycle next. It's a discouraging time. But I think you've learned a couple things. EEG measures cortical recovery. It starts suppressed, and so burst suppression may be a milestone on the way to goodness. But having epileptiform discharges is potentially detrimental, and it would be better not to have them. Claudio Sandroni wrote a review that's available this year. It has pictures of all these things. It's a really nice paper. On my screen, it has the reference put out there, but it's in Current Opinions in Critical Care. And you have pictures of all of those types of discharges. And he also summarized, well, what's the significance of those? If you start suppressed and stay suppressed, that's bad. If you start continuous and continue to be continuous for 48 hours, that's good. And then you have different combinations in between. So his recommendation was, get the EEG initially, then get it again sometime later, 48 hours, somewhere in there. And those two pieces of information will tell you something about the trajectory of that patient. So just like the data I showed you, if you don't have continuous EEG, getting two snapshots will tell you something about how the movie is unfolding. And 48 hours is a reasonable time frame to be looking at those snapshots. A lot of combinations there. Oh, reactivity. Here's another term that your physiologist may report to you and say the EEG was reactive, but you can do this at the bedside as well. If you have brain waves and then you do something to the patient, like pinch them or stimulate them or shock them, then the EEG changes in amplitude or frequency, then that's a reactive EEG. Any response of frequency or amplitude to a stimulus would be considered reactive. And that's kind of important because if you have a reactive EEG, like the one at the top, that suggests that information is going to the cortex and it's getting processed. It's changing the cortex. It may not be normal, but it's doing something. But if you have something non-reactive where the EEG doesn't show any change when I stimulate the person, then you can't be sure that the cortex works. Information comes in from the periphery, and then it may not be doing anything. And this is highly correlated with good outcome. If somebody develops a reactive EEG, then 80% of those people in the series that have been published have good outcome. So the recurrence of a reactive EEG is one of the strongest sources of enthusiasm you can have when you're monitoring the patient. All right, what about treating seizures and all that? We've seen the seizures. I've told you that they're bad news. They reduce the likelihood of recovery. Can I treat them? Or is that futile? There's a trial, and this was done by an important group. It's done at a number of hospitals in Northern Europe. It took not so many patients, 172 patients, and they randomly assigned them if they had an EEG that had periodic or epileptiform discharges. So the patients weren't floridly seizing, but they had these malignant EEG patterns. They said, well, let's treat them with anti-epileptic drugs or not. Just sedation as needed and then see how they do. What is their outcome at 3 months? They show us pictures of what they're talking about. And these are the tracings of patients with these rhythmic patterns. The time scale there is more compressed than the one I showed you on my tracings. And you can see that those are those epileptiform discharges at pretty high frequency, sometimes with background, sometimes with no background. So these are the patients that we're talking about, and they resemble my patients that I care for. These are some other tracings from there. This one actually shows the progression over time of somebody who starts suppressed, develops some epileptiform discharges that increase in frequency until down here they get so fast that you would call it a seizure. And be obliged to treat that because now they're in status epilepticus because it's more than a couple of times per second. They didn't find any difference. So in their trial in the New England Journal, the soundbite, the thing that said is treating with anti-epileptic drugs did not matter. But you gotta look into the details because they had not everybody the same. They had people with generalized periodic discharges. And some of those were slow, like that top panel A. And they didn't seem to do any better with anticonvulsant therapy. But they also had people who had fast discharges, seizures, or they had evolving discharges where they were increasing in time or increasing in frequency over time. And in those groups, the only survivors were people who were treated with anticonvulsant drugs. There were no good outcomes in the people who were not treated with anticonvulsant drugs. So the anticonvulsant drugs had benefit in some subgroups that you could probably tell apart at the bedside from the other patients. They also show you that the survival was always in people who had background, and that the people who had discontinuous or suppressed background for the whole study, none of those people had good outcomes. So the background really is very, very important. And then whether your discharges are just repetitive discharges on a flat background, which is bad news, or are they discharges that are changing over time that's maybe a seizure that you can treat, matters. Suggests that there are two flavors of patients, even though, both of them would be described potentially as has some epileptiform discharges. On my last lecture, I also pointed out that you have to have healthy skepticism of data from America and from parts of Europe because of withdrawal of life-sustaining treatment. We're getting better as we do trials to try to regiment this and to record it and to pay attention. But remember I said, if the patient looks bad, then the doctor may think they look bad, and then they may do something that affects the outcome. And in some places, the thing they do is to withdraw the ventilator and let the patient die because they think, oh, he's going to have a bad outcome. Having seizures is one of those things that may make the doctor think that this person will do poorly. And the literature I showed you would support the doctor, and the guidelines I showed you would support that conclusion. And in fact, nowadays in a trial, we expect to see this kind of graph where we report who had withdrawal of life-sustaining treatment and was it different between the groups? Was this changing our results? Yeah, look at the weight of when people had withdrawal of life-sustaining treatment in this trial between the treatment group and the no treatment group, between the control group and the intervention group. Maybe 5 days if they were getting treated with drugs, maybe 2 and 3 days if they were not. And sort of the weight of the curve is different between the two groups. So I think this is evidence that that thing is really having an impact on the treatment aside from what the patients were randomized to receive. And it makes you wonder about the survival curve, because if I looked at the intervention group and the control group in their survival curve, they were starting to be different up until 8 or 9 days. But then there's a great wave of withdrawal of life-sustaining treatment, and then they're all the same. So I worry about the conclusion that outcome at 90 days is clearly not affected by the intervention, because there was intentional sabotage in the first week to remove patients who didn't look so good. So I don't know for sure that if I give an anti-epileptic drug to someone who's having epileptic discharges, that maybe that will help them, but it may take me many weeks to appreciate it. We found in our own data that the ease with which we treated the seizures also predicted the outcome. So if I was able to get control of the seizure with one drug, those patients did not so bad. But if it took 3 drugs, 4 drugs, 5 drugs to get control of the seizure, my survival and my modified Rankin score, my good neurological outcome went down with the more drugs I had to use. So the responsiveness of the seizure or the epileptic discharges to drugs is also a piece of information that tells you about their outcome. Okay. Let's bring this stuff to life. It's a patient we saw just about a year and a half ago. He's 56 and he had a cardiac arrest. His witness collapsed, got CPR. Total CPR is about 15 minutes. Relatively easy to reverse. Ultimately, his etiology was a cardiac event and he had interventions in the hospital to correct it. But his neurological situation was worrisome. His initial examination was not so good. PCAC4, my category 4. He had brainstem reflexes missing, did not move his extremities. His CT scan of his head was okay. The gray-white ratio was normal, so no edema, no brain edema. And his EEG is very suppressed. And I'm hoping that that's, evolution to good EEG. It's not malignant. So he gets temperature management. We do 33 degrees for our PCAC4s. Here's his initial EEG. Has suppression and then has some brain waves. We're going to point to a couple of things. There's some waves that are sort of sharp, look maybe a little worrisome that they may turn into those epileptiform discharges. Remember, nothing in your EEG should look like your EKG. So if you see anything that looks like an EKG, it's not good in your brain. And it actually gets worse. So as the days go on, he gets more and more epileptiform discharges with suppression in between. In fact, his clinical course takes a bad turn. The discharges get worse and worse. We add drugs. He's on anesthetics, propofol. By day 3, he's on multiple medicines, levetiracetam, lacosamide, propofol, ketamine, midazolam. And anytime we try to reduce the anesthetics, seizures, he has electrographic seizures. We really cannot turn anything down. We just have to keep adding things in order to control it. But when we give a bolus, when we give drug, it's encouraging. They'll have strips like this, lots of discharges. You come along and give a bolus of midazolam or a bolus of propofol. Nice, relaxed. It looks good. Suppression happens, but the discharges are very responsive. So what do you think? What's giving me enthusiasm about this patient? He's promptly responding to drugs, but he's taking a lot of drugs. He had a background initially. So when I first put on the EEG, was not flat. He had cortical activity. And even when I suppress seizures, there's some cortical activity behind it. I expect some suppression just from anesthetics. But there's clearly brain waves that are normal brain waves behind the seizure. And he had good imaging. So some doctors who were taking care of this person by the 7th day in the 7th anti-epileptic drug were asking about our science experiment. Were we actually doing, proper by this patient? Did we really think that he would be able to be salvaged because he was so difficult to control the seizures? But these things made us persistent, and we were able to continue treating him. We added clonazepam. We added topiramate. On day 8, he had evoked potentials, and his cortical evoked potential, his N20s are absent. More seizures, more responses, winds up on phenobarbital as well. And by day 11, the seizures start to subside. What do you guys think about the evoked potential? Because if you remember your guideline, malignant EEG, absent evoked potentials, bad exam, bad outcome. Thoughts on the evoked potential? This is a good time for me to pause and let your own brain work.
ABICU. And sometimes they, well, not only in like post-cardiac arrest patients, I also think about other patients. But sometimes we do that early and then second time, first time they don't pass, second time they pass. So we see it's important to do it all the time.
Yeah.
And sometimes, especially in cases which are not like post-cardiac arrest, it can be a little bit confusing.
Yeah.
The experience that has.
Yeah. Yeah.
They don't always help or not always help.
Yeah. Yeah. So despite the reputation that, and just I'll repeat that for the microphone, there's clinical experience in the room that evoked potentials will sometimes be absent and then repeated at a later time will be present. And that's true in different patient populations. They have a reputation in cardiac arrest of being the most specific test for cardiac arrest patients. You know, that if you have absent evoked potentials, the patient will not wake up. But, you know, I think this case, look at how many medicines he's on. He essentially has general anesthesia right now with 4 or 5 anti-epileptic drugs. I don't think that there is a large literature on the reliability of evoked potentials in the setting of that large pharmacology like we're doing to this person at that time. So, you know, I agree completely with your observation. This is evoked potential. It would have been nice if it had been present and it would have given more enthusiasm. But we also had discussion. There were some doctors who were saying, see, I told you this person is devastated. I don't know why we continue adding medicines every day. And the other said, I don't trust it because he's on so many medicines that we've added. I think we have to continue on and then, you know, hope for improvement later.
How do you make or prognosis? Usually, like with drug sedation after slower than if possible, or then with EEG and drug protection again.
Yeah.
It's really, you don't necessarily need to do sedation for people, but we tend to do it anyway because of the timing and because we really need at the same time. You suggest monitoring drugs without sedation anyway.
Yes. So yeah, and to repeat that, it would be much more trustworthy a test, more reliable if it was done without sedation. But you can see in real practice, this patient, if you stop sedation, he seizes. In fact, we have been escalating sedation, adding barbiturates, adding midazolam. You know, we've only gone up on the sedation, never down. Anytime we go down, he has seizures. So sometimes clinically, you cannot use the test. Exactly right. Eric, I'm sorry.
Yeah, Thomas from the audience is asking if the patient was reacting.
Yeah. Sometimes with stimulation, we would see reactivity with the EEG. It's difficult to document with this high degree of anesthesia, but he is, you know, particularly when we did evoked potentials and you were doing electrical stimulation, you could see changes in the EEG. In the second week, no, the third week, the seizures start to come down. It's a long time. And, you know, here's day 12, still lots of epileptiform discharges. That looks like EKG, yeah? That's why they put the EKG lead on your tracing so you can be sure that it's not accidentally picking up EKG in your brain. If you can see the EKG on your brain, that's a sign of very large suppression. If this is EEG and it's
Or brain dead.
or brain dead, yeah, it's bad. By day 16, there's his exam. His pupils, corneals, gag, cough. He flexes. So at least his midbrain is working. I don't really have cortical signs. He gets a feeding tube, tracheostomy by this time. We discovered that, again, to answer the reactivity, his seizures are reactive. So sometimes suctioning or moving him is what triggers a seizure. And as a consequence, we give analgesics before moving or manipulating the patient. repeat evoked potentials now on day 19 are present. So we come back 10 days later, and as your experience, now you can detect a cortical response. His seizures are really controlled with this large number of medicines, and by day 23, he actually liberates from the ventilator and stays on trach mask thereafter. And EEG starts to look like this. It's got brain waves. You can see there are kind of some sharp-looking things running through it. And if you turn down some medicines, they get bigger. So he can still have a seizure. If you stimulate him, those things will become more active and he'll look like a seizure. But, there's a lot of brain activity there. By day 32, he opens his eyes. He starts to track and look at you as you walk through the room. He actually verbalizes. And then by 2 months, he actually can have a conversation. It's slow recovery. And it's really in the second month that we're able to begin reducing some medicines. So I think that's an important thing about status epilepticus in these patients. It's not a fast recovery. And patience and persistence are really a common feature of the patients who come through that highly malignant seizing EEG. He actually comes back 1 year to visit the ICU. And our incredible health system in the United States, he had been lost to follow-up and had not seen any doctors. So as he ran out of anticonvulsant medicines, he stopped taking them. So by the time he comes back, he's only taking one of his anti-epileptic drugs, but he hasn't had any more seizures. And he goes to the gym and is managing his own house and living with his sister that you can see walked in, uses a cane, but no other assistance. So that's a long bout of status epilepticus, and yet the recovery long-term can still be good. That kind of experience worries me very much for clinical trials where we had 50 or 60% of the patients had withdrawal of life support on day 5. So treating seizures, yes, is another intermission. Things that give you enthusiasm, like this patient, responded to an intervention. I gave a bolus of propofol, seizure stopped. It responds. If I had given boluses and nothing happens and it's seizure, then I would have had less enthusiasm for continuing on. And seizures that are intractable to multiple drugs are worse, but it can take weeks for people to recover. How long should we monitor people? How long should we be looking for this? Well, we've been using EEG to find people like this gentleman. And the tracings over 5 days show a lot of evolution. And you can see that of people who start out with a suppressed EEG, maybe 50% start to get epileptiform discharges in those first few days. People who start out with a continuous EEG, it's less, so continuous EEG, you're at less risk. And people who have a discontinuous EEG, they get some progression over the first few days as well, more epileptiform discharges. And other people have similar kinds of results. Over 3 days, you see that those continuous backgrounds become continuous and good within the first 2 or 3 days. This is from Dr. O, I believe, in Korea, and Dr. Kloostermans, also from Netherlands series. Really a lot of evolution in the first 48 to 72 hours. One of my partners described the incidence of patients with favorable or unfavorable patterns over time. And these are not our data. These are data from Dr. Hoffmeyer's group in the Netherlands. The proportion who have favorable outcome and favorable EEG is there in green and red, And you can see that the favorable EEG patterns become evident really within 72, 96 hours. There's not a lot of changing in the character of the pattern after the third or fourth day. And these are our data from my colleague, where he asked the question, if I've been monitoring the patient since arrival on the EEG and nothing bad has happened, how likely is it that something bad is going to happen in the future? Which is really the question you need to ask about whether I can turn off the EEG and give it back to the neurophysiologist. From a practical standpoint, in my hospital, we have 10 machines for continuous EEG. We have neurosurgical patients, stroke patients, cardiac arrest patients. Everybody would like to monitor the brain all the time, but we have 10 machines. So there's a great incentive to decide I have monitored long enough and I should give the machine back to the pool so that other people can be monitored. You can see that when seizures develop, for our series, they almost always develop by day 3. And the likelihood that something malignant was going to happen went down close to 0 by day 3. There's wide confidence intervals because, we only have a few hundred observations, but that, I think, gives you a sense that the most critical time to monitor the patient this way is in the first 3 days. And if nothing bad has happened, you can probably be done. It's different if something bad has happened. If you're seeing epileptic discharges, well, this is the pathology we're looking for, and now you have to decide to treat them. Those people may be on monitor, like my patient I just showed you, for 2 weeks while you're titrating lots of medicines. And maybe after 2 weeks, you know what's going on, and you can take the EEG off and just come back and check it every day or every other day and reduce your usage. But the continuous EEG has become our standard practice for the cardiac arrest patients for the first 48 hours. We decide about the next 24 hours at that point, but we monitor essentially everyone for the first 48 hours. We will stop if they wake up. So if they wake up and ask what all the wires are, it's not necessary because I have a good clinical exam. I've avoided this topic because I hate myoclonus. Status myoclonus is the most biggest buzzkill. You know the term buzzkill? No. This is a jargon for something that makes you stop having a good time. So if you have a cardiac arrest patient, you're enthusiastic, this person, we're going to do everything possible to make them have a good outcome. And then they start having status myoclonus, the jerks. It makes my stomach sink, and I think this is bad, sign of bad damage. Looks like this. There's a case very typical for status myoclonus. It's a 65-year-old woman with lung disease, COPD, and she had a cardiac arrest. It was not shockable, and she's got pulses restored relatively quickly and doesn't have any signs of cardiac. It looks like it was a respiratory event. She had high carbon dioxide and probably had hypercapnic respiratory failure leading to her cardiac arrest. Her initial EEG was not so terrible. It had brainwaves and a lot of EMG artifact. All the fuzzy stuff is too fast to be brainwaves, so it must be muscle. But you can see in some of the other reads where that artifact is smaller that there are some activity. And there's not spiking activity. It's the malignant stuff. She has a good imaging of her brain, gray-white features of the brain are preserved. And her examination is equivocal. Has a pupil response, but no corneal. Doesn't really move her extremities. And so we place an EEG and support her in the ICU. And I noted already the continuous background activity. But on her first 24 hours, she has an episode of jerking. The nurse's call says she's having a seizure. And it stopped when they gave lorazepam. But she continues then to still have jerks. And every once in a while, she'll have an abdominal jerk or a body jerk. Is this a seizure? Is it myoclonus? Is it shivering? It's sometimes hard to tell. Her EEG has now epileptiform discharges. And you can see the spikes on those tracings where there's not EMG artifact that look like EKG marching through. This is a movie. I can't show it to you here on this computer, but it has a little bit of a tracing on this computer, which for those of you in the room, you can play. No. Well, we'll try it some later time to see if that's a movie that you can see. But you've seen the jerks, and they continue with those epileptiform discharges. And they have discharges that are kind of identical. And so this is where I want to talk about another piece of jargon, which is identical bursts. Identical bursts are a burst, but the first part of it looks the same. So if I look at somebody's EEG and I see those tracings and there are discharges, they all kind of look the same. Some patients also have flat background and they have discharges that look the same. With those are highly correlated and the pattern is almost identical in that first half a second. They refer to it as an identical burst. And that can be bad news. Status myoclonus, where people have the jerks, often has a burst suppression pattern, and the bursts correspond to the jerk. So it's kind of like a seizure because there's an EEG correlate, but it's not really a seizure because it's not really evolving in time. You know, it looks different than that person who had status epilepticus, where it's just continuous epileptic discharges. It's a burst. But the first part of the burst looks the same every time. And that identical burst may be all you get. Here, you can see that all those bursts look alike. And then they may evolve into that seizure. Again, that's Hoffmeyer's data. And it may or may not have background brain waves behind it. This, I think, was, if I had to think of the thing we came to understand the most from EEG in the past 10 years, this is the thing I think is the most important thing we've observed in cardiac arrest patients in the past 10 years. On the right, you have a suppressed pattern and a burst. In this patient, every burst looks the same. They're identical bursts. The first part of that burst is always a spike going up and then down, and it looks the same every time. Person on the right also has bursts, but they've got brain waves behind it. Their background is not suppressed. And what happens for these is that the one on the right is malignant. It's malignant myoclonus. It's generalized. It can be stimulus-induced or not. So clinically, it's the same as Lance Adams, which can be generalized, can be stimulus-induced. SSEPs can be present or absent, and SSEPs can be present or absent in the Lance Adams. But the background is different. The EEG background is different. I'm going to show you a couple more pictures of it so you'll know it when you see it. Here's one where the bursts come. They're very brief, mostly suppressed. So the background, is it present or suppressed? Suppressed. And then there's a burst, and the bursts look the same. Real spiky, angry looking. Later, it changes a little bit, and you might think, oh, maybe here's some good brain activity behind it. But the identicalness of it is determined by that first half second. So you can see that even though the second one has a little tail, the beginning of it is identical. So these are still identical bursts on a suppressed background. And over time, sometimes it lasts for the rest of the patient's life. Sometimes it burns out over 3 or 4 days and goes to a very flat, attenuated background. And for this patient, that was the case. It became suppressed. And that's what his EEG looked like for the rest of his life. No good. Other pictures of the same thing. But here's a different one. This person has these discharges or bursts. If you line them up, they're identical. They have the same shape, but there's a background behind it. And one of the things we've observed with this variant is it's more likely to be localized as well. So these aren't all over all the leads, but you can see that they're bigger in certain leads than others. And they tend to be more on the sagittal part of the head. They also can be in many places, but the key thing is there's a background. It's not all suppressed. And over time, this person improves and has good-looking EEG and awakens. 1 month later, but they still have those discharges. The pathology is still there, but this person is now awake outside the hospital and may actually still have symptoms from it. In our hospital, the malignant pattern rarely results in survival and never in good outcome. But the other pattern, 50% of those people awaken and can have a good outcome. It's not guaranteed. Some of those people are devastated and have tracheostomy, feeding tube, never regain function. But it's a big difference, 50% and 0%. I am absolutely certain that before 2015 or so, that I withdrew life support and told families that there was no chance of this person with myoclonus waking up and that I was wrong. And that some of those patients, apparently 10% of the patients, 15%, would have had a chance of recovery if we had persisted in our treatment. So again, I think this is a critical observation. One of the things, I think, one of the most important observations in the last 10 years. This is really common. Remember earlier, I had maybe 20 or 30% of the patients who come to my hospital have myoclonus. 10% of them can survive. I don't know who they are until I put on EEG and monitor it. So that is a key use of the EEG. Long-term management of Lance Adams involves drugs like clonazepam, levetiracetam, valproic acid, but it's also not an emergency. This is a movement disorder. So suppressing it in the ICU is not an emergency. It's going to have the same long course, and you need to figure out medicines that that person can wake up on and then go home on. It's more important to see if they're going to wake up. So if I start loading them with phenytoin and valproic acid and have 3 or 4 medicines to try to make these jerks stop, it gets confusing. Now 1 week has gone by and they're not awake. I don't know, is it because of bad brain injury or is it because of all the medicines I gave? So we have adopted a strategy of just using short anesthetics for the jerks. And we'll sort the patients out under anesthetics and try to avoid anti-epileptics until we're clear, is the person on a trajectory to wake up, or is it something where they're going to stay devastated? I can turn those off and in a few hours have an exam to help make that decision, but I can't remove the phenobarbital or the valproic acid so quickly. So remember my woman with respiratory arrest, and she started to have a seizure in jerks. Her EEG has background. I'm thinking, this could be Lance Adams. That would be great. We add Keppra and use propofol, and she actually has seizures, which is why she gets an anti-epileptic compared to someone with just jerks. So she actually had a first episode, but that doesn't really recur. And her EEG, still has those discharges through it. But after we give boluses, it gets better. So it's like my other patient. It responds to drugs. So I'm enthusiastic to push on. And then by the third day, she's not having any seizures, but she still has some jerks. We had clonazepam because we think that if we get her off anesthetics, without becoming desynchronous with a ventilator, then that's her best chance of waking up. Her EEG is, a little better. Still has lots of discharges, but lots of brain waves behind it. And in the first week, she has ICU problems, things we have to manage. We trial some other medicines. We do an MRI to be sure that, there's not some pathology we're missing and it's benign. This gives you a feeling for what you're dealing with that pharmacology. There's a burst of spikes that goes along with her jerk, and then long periods with no jerk. So she may only have a jerk once a minute, once every 2 minutes. It's not so bad. By the second week, we can get her extubated. She does not succeed. She has to be reintubated. She gets a tracheostomy. And it becomes a kind of balance with giving her medicines that do not sedate her and ones that allow us to control her jerks. So she spends the first month in the hospital really titrating medicines and actually winds up on a smaller dose of clonazepam and a smaller dose of Levy. And before she leaves the hospital, she's awake and interacting with me. You can have her do an exam, but the interesting thing is she still has myoclonus. So if I have her do finger to nose or move her legs, she actually still has a big jerk once in a while, but wide awake. And so that's a really important thing to remember when you see the person jerking in the ICU. It might be one of these where that's going to be a movement disorder that now you're going to have to manage in clinic for some time, not something where you should withhold therapies. So she actually came back to another hospital 2 months later because she had a mucus plug in her tracheostomy. And because of the change in institution, she did not get her clonazepam for a day or two there and had a recurrence of bad status myoclonus, but got loaded back and had to leave. So she remains dependent on those medicines for many months and maybe for the rest of her life. Ultimately goes home alone. She actually, went back to live alone and doesn't remember too much, but returned to her baseline functional status with a tracheostomy. Just to kind of give you another perspective on that, a younger man with a cardiac arrest from a acute myocardial infarction. He comes in also after long CPR and has his cardiac intervention to treat his myocardial infarction. But he develops, again, jerks and seizure. This is one of the beginning cases where we, I think, began to realize that these patients may be salvageable. His CAT scan was so-so, and his exam was, again, not encouraging, but his EEG was very responsive to treatment. If we gave medicines, we could suppress the jerking activity. And by 1 week, he improved. And by day 18, he's actually going to rehab with some memory problems and still some jerks. So he comes back some months later and is an engineer who has returned to work. And his myoclonic jerks interfere with his pastime, which was racquetball. So his number one concern was to try to find a medicine regimen that would control the jerks and allow him to still play racquetball. So, status myoclonus, again, sometimes is this. And I am certain that I have not saved some patients who could have survived. It's not a seizure. It's not epileptic seizure. It's often bad news when it has those identical bursts and suppressed background. But sometimes it's not bad news. So hopefully that's something that many of you will take into your practice. If it's not epileptic, what is it? Looks like that. maybe we could figure out where it's coming from. I had a medical student who did this as her thesis. She took the identical bursts and compared patients who had jerking and also patients who had generalized discharges and no jerking. She found that when they were identical bursts, if you look at the correlation in the electrical activity between two bursts, and she did that for all the bursts that the patient had, the identical bursts had a really high correlation. So this is just the distribution of correlation coefficients between all the bursts in that patient. In a person who did not have identical bursts, it was broader. They sometimes looked alike, but they weren't as tight as the identical bursts. So we can make a real rigorous research definition of identical bursts. And then she took advantage of the fact that EEG is all over the head. So you can tell something about where things are coming from. If a wave or a discharge starts in the front of the head and moves to the back, it'll be a little bit delayed as it goes from the wires in the front to the wires in the back. And likewise, if it's going from the back of the head to the front, it'll have a gradient. Well, there is software where you can take all your EEG, put it into the software, process it, and make maps of where those discharges go. I love this because I love pictures, and those are nice, colorful pictures. And it reads like a book, from left to right is going evolving in time, and from top to bottom evolving in time. And you can see a discharge from one of these patients with myoclonus. It starts in the middle on both sides, and then it propagates across the brain down the central gyrus, and then doesn't really get into the occipital lobe quite so much. Here's another one. This one starts sort of in the posterior right and then evolves from back to front. What my student figured out was that the patients who jerked were the ones where that discharge was going across the motor cortex. Seems obvious. But, it sorts out that if there was a lot of electrical discharge that propagated across the motor cortex, that's when the person had a jerk. And there were other people who had identical bursts that looked electrographically the same, and they don't jerk. And it's really just that the electrical amplitude across the motor cortex was not so much. So the jerking is not the pathology. The problem are those identical bursts. And they're probably all the same syndrome, EEG with identical bursts. And the key thing is whether there's background or not. The jerks are related to just the discharges. The background is the thing that's driving whether that person's going to have good outcome. Second observation, the proportion of my patients who have bad CAT scans I talked about in the last lecture, it's a lot. And that's where people who have brain death come from. And people who have these EEGs, it's another 20%, and that results in bad neurological outcomes. They don't overlap so much. The people who have early brain edema, their EEGs are pretty flat. They don't seem to have many electrical discharges. 95% are just suppressed EEG. And the people who have those malignant EEG patterns, they don't usually have the severe edema. In fact, the timing of duration of CPR between these can inform us a little bit. This is a presentation of just the previous slide. People have edema, or they have identical bursts. You can see it's 10% of all the cases, and maybe 20% of all the people who die. And the Venn diagram shows you that those two groups, they don't overlap. It's very unusual to have early brain edema and identical bursts. And if you look at the duration of CPR, having brain edema becomes more common with a longer CPR. Having identical bursts becomes more common after 10 or 15 minutes, but then it becomes less common because you have brain edema. It sort of implies that those two things are part of the same syndrome, maybe on a continuum. First, you have coma, then you have identical bursts, then you have cerebral edema. And my colleague, Dr. Koppler, he is put a graph to show you the likelihood with different durations of CPR of having one or the other of those syndromes. It's much more likely to be awake immediately if you had only 5 minutes of CPR or less, and becomes decreasingly likely over time. It's much more likely after 30, 40, 50 minutes of CPR to have early cerebral edema. And then the coma without a malignant EEG is the thing you see after 10 to 15 minutes, and coma with these identical bursts and malignant EEG is what you see after 20 to 30 minutes. So it sort of speaks true to the amount of damage. Knowledge gap, myoclonus, we don't really know what the substrate for it is, where it comes from. I think Amanda's data suggests it comes from the midbrain, because to me it looks like those bursts are showing up on both sides of the cortex all at once. It makes me think that there's something that's coming up from down below and then appearing on the cortex. I'm going to wrap up here. This is my reminder to wrap up. That's my hospital. We have gone through a lot of neurophysiology, more than you wanted to. Continuous background is really important for awakening. Return of EEG reactivity is like the best sign for you're going to wake up. Malignant patterns, if they're going to happen, usually show up in the first 48 hours. Epileptiform discharges might be treatable, might not. Really depends on your background, and then you can tell a lot from how responsive they are to drugs. Status myoclonus has at least two flavors. One is very malignant, and that's the more common, but some is quite survivable. And if you wanted to remember how to interpret EEG when your neurologist is sleeping and home and comfortable, you can talk about the background. Is it discontinuous or continuous? And you can talk about whether they're discharges, yes or no. It's better to be continuous with no epileptiform discharges. It's worse to be discontinuous with epileptiform discharges. So, you want to be in that top right corner, not in that bottom left corner. And it really is a supplement to doing your physical exam to see if the motor response is present. I think you should be treating epilepsy and epileptic discharges and seizures, but I don't know about GPEDs. Just see those things marching along and it's not clearly a seizure. That clinical trial does not support treating those with anti-epileptic drugs. Refractory seizures are a poor sign, and recovery and treatment of these patients requires patience. It can take weeks for the good neurological outcome to be evident when somebody has this much brain injury. So again, have patience. That's it, and I'm going to stop there. I really appreciate you all being engaged, and it's an honor to speak to you. Thank you.